So we know that one of the key issues is the cost, the cost issue, because we are in a certain way some kind of the seller of these lenses. We need to demonstrate to the patient that there is an additional value for them to get these lenses. So can you maybe tell us about how you do prepare the patients, how you do select them, and what kind of things you would emphasize to get them ready, not only for the nice effect, but some potentially dysphotopsia and so forth. So is there specific, I would say, preparation in terms of how you manage them?
I work in the public system, so that means I don't we don't have co-payment in Austria. So we'll have differences here in the different countries, of course. And so that means if I give a patient a multifocal lens or an EDOF lens, we have to pay it out of our budget. So we are obviously a little restrictive. In a private setting, it's a little different again. I think from my perspective, what I always want in these lenses, especially with trifocals, I want to have a really healthy eye. I think that's important. You don't want one of the three main causes of poor vision in age, meaning a diabetic who may develop diabetic maculopathy in the next 10, 20, 30 years, because these patients have a long life expectancy if we operate them in their 50s or 60s. You don't want to have any drusen or early AMD changes from my perspective, and also glaucoma is for me a no-go. So I think that rules out quite a few patients actually, if you think about it.
And don't forget dryness.
And then comes dry eye and others, which are maybe a little more relative for me, relative contraindications. So that's the way I tackle it concerning the patient selection.
We have a co-payment system in our country, and beginning of all, of course, there needs to be a clear wish for the patient to be spectacle independent most of the time. That's for me a very important point. And then, in addition to what Oliver is saying about your healthy eyes, I think that we now implement some diagnostics we were not doing 5 or 10 years ago. We use regular OCT measurement of the macula
for all the patients,
for the multifocal patients and so on, to see whether to also pick up these eyes where we wouldn't see abnormalities with ophthalmoscopy. So that's something that we have changed in addition to looking for dry eye and so on. And you have to educate them, of course, on the potential side effects. So if you do that in a structural manner, I think, and you are honest and direct in your communication mechanism about what patients can expect, I think they are also most willing post-operatively to accept that.
Thomas, maybe you can also comment about what kind of, I would say, post-operative expectation you tell to the patients, especially for, I don't know, night condition and this kind of limitation on which we need to focus on before the surgery.
Let me first take, I think that the preoperative evaluation is very important. So we have in all these patients, we have a really strict criteria. We do several measurements looking at the macular function, looking at the endothelium, looking at irregular astigmatism, topography, tomography. If you have done this, then I usually go, my first step is usually I educate the patient what options they have, but I usually select the lens which I think is best for them. And then I tell them this. In Germany, we have a clear system like a co-payment system, and I think it's very easy because a monofocal lens is there, then you have 3 times pay, a third for toric lens. Defocus, depth of focus lenses are actually a third more, and the trifocal lens even more. And that's actually reflecting what they can. If you only correct toricity and monofocal lens, then the other thing is depth of focus, and the trifocal basically are the best in terms of looking at different qualities. That makes sense. Patients understand this very well, and the beauty of this co-payment system is they can all decide what they want. If they want the regular system, that's fine, but we give them the option. Actually, we have figured out that if you don't tell them that there is an opportunity for this, patients are really not satisfied. I get several referrals from other clinics where they have never spoken about this, and that's not good. And the patient tell me, why nobody has told me about the opportunities? So I think the education is there. We need to educate our patients. In terms of post-operative, maybe very shortly, I think it has to be clear, if you do depth of focus, Rudy and Oliver just pointed out, you will have optical symptoms, and you also have them with trifocal lenses. But with this new generation, I think they become so minor if the selection is good. And selection means treatment of astigmatism, treatment of dry eye preoperatively. So if you're doing all these things and your selection is good in terms of good optical quality and media, then the patients tolerate the symptoms. And you also tell them that usually over time they decrease. I have personally not had to explant a trifocal lens on also not a depth of focus IOL, but I had to do it in patients outside if the expectations were different and if the patient was not educated very well.
I fully agree. I think that the patient needs to know that there is no way to go back to the eye of the 20s. And so that it is going to depend on the surrounding condition of light, the condition, of course, of the comfort for driving at night. It's not going to be the same. So that's definitely true. I get that when the patients know what he can expect, that avoid any source of disappointment. So I think that we understood, according to your comment, that we need to target emmetropia for trifocal, any kind of multifocal, I would say, and EDOF are more forgiving. So we know that we are able nowadays to correct astigmatism. So can you make a comment about the interest of combining toric lenses to all this profile, and what are the thresholds for you for indications if we think about EDOF and trifocal, for instance?
No, I think for astigmatism in presbyopia lenses, we really know that you have to target for a low amount of residual astigmatism. So 1 diopter or 1.25 diopters of residual astigmatism, that's really not acceptable. That's not going to work. We know that from the work from Hayashi, what has been published years ago already. So I think you have to use a toric version, or in some instances probably you can combine it with relaxing incisions, although they are less predictable, of course. But my preference really is going for toric IOL in those cases where you have well, depending on the axis that you do the surgery, of course, where the steep axis is, but 1 diopter or 1.25 diopters of astigmatism, you need to use a toric IOL.
I just reviewed my data. In a case of 3,000 femtosecond laser cases where potentially you have presbyopia-correcting IOLs, we had 60%, 65% of presbyopia-correcting. That's a high number. And the other 35 was basically monofocal lenses. In the monofocal lens, we had aspheric lenses, and a third, so aspheric and aspheric toric, a third of them were toric. And if you look at the presbyopia-correcting, same thing. We had presbyopia, 66%, and the other 33% were toric presbyopia correcting. That means we're correcting really down, as Rudy pointed out, below 1 diopter, or basically below 0.75, 0.5 is even better, because particularly in the presbyopia correcting IOL, you have to do it, because the focus on the retina have to be, spot on. And if you have residual astigmatism, it doesn't work. That was 20 years ago the big problem of multifocal lenses, that they had no toricity, they couldn't correct this, they had so much variation in calculation that it doesn't work.
We know your expertise, Oliver, in the field of calculation. What is the place nowadays, especially talking about the small amount of astigmatism of the posterior astigmatism, and what is the level of accuracy that we can expect? Maybe some tricks about that formula?
Absolutely. I think the less the astigmatism, the more difficult it is to assess. If we have a patient with 3 diopters with astigmatism, no matter which technique we use, a keratometry, a topography, a tomography, will have a very similar result. They will be usually very, very similar, and also to the glasses the patient has. When we come down to 1 diopter, 0.75, and we take these different techniques of measurement, they're all over the place sometimes, not always, luckily. And I think that's really an important issue, and especially that's where dry eye plays in. If the patient has a dry eye on top of that, every time he blinks, you have a slightly different measurement. So I think what you need to do in these patients is you need to make a series of measurements with different machines, which we do for all toric lenses, but here especially with the lower astigmatism. And then you need to compare them. And if they don't compare well, then you probably have to try to find the reason, and have to look at irregular astigmatism, dry eye. If it's dry eye, you have to treat the dry eye, redo the measurements, and hope that you get better measurements. And if you don't get good measurements, just leave it. Don't do it. And then these are probably not good candidates for presbyopia correcting lenses anyhow. Yeah. So I think you have to be meticulous, and then the formulae, there's several out there, and the modern ones, they all work quite well. But really, the measurements, I think, is a critical point from my perspective.
But that's only the measurements, because after that you have the surgically induced astigmatism that can vary.
What about the
You have
rotation, by the way, Rudy?
You have the rotation, you have the alignment on the
That
axis.
adds on. That adds on.
That adds on, and well, we know that you only can achieve a certain amount of accuracy in alignment, which is around 3 degrees. Better is not possible, whatever you're doing, whether it's digital or whether it is manual marking. So there will be certain limitation. Now, in the low levels of toricity, that's probably not that big a problem, actually, if there is a 3 degrees misalignment. But in the higher levels of astigmatism,
Yeah, of course,
then it is certainly a big difference.
Let me add to Oliver's point. For those who are going to start these lenses and would like to use them, you have to be willing, when you start using these things, you have to be really ready for taking all these preoperative measurements. You have to take the time. It's not like you go in a cataract, take it out, do the lens, and no. You have to take time. It's preoperative measurements. It's the talking to the patient. It's time consuming, but it's worthwhile doing it because your outcome first of all, they get better, and the patients will be more satisfied. But you have to be ready to do that.
You were mentioning previously a huge series of flags that you can use, of course, in this kind of premium surgeries. Is there a place for relaxing incision based on the laser when we are talking about the correction of this very small amount of astigmatism compared to a toric lenses? I mean, there's a debate around that?
Yeah, that's a very good question. If you look at just because we reviewed 3,000 eyes, so the first 10,000 were maybe 10% relaxing incision. And then we went a little bit down to 8 to 5. And the reason is that we use more toric lenses, like Rudy pointed out, more toric, but we still use them. And of course, it also comes back to the point Oliver made. The measurements have to be even better, and then we can even go to smaller amounts. So I think that combination of the toric version with a little bit of basically limbal relaxing or basically as laser keratotomies can be very effective, but we have to learn more about it, really about our nomograms and how to combine it. But this all can add up to a very nice surgery.
You know, I have not seen a very well-designed study on this yet, actually, but we've done a comparison study, and that was not only focused on the low degrees, you know, it was up to 1.5 diopters, actually, so not only 0.75 and 1. But my impression from that comparison was clearly that toric IOLs do better than even than the arcuate keratotomies made by the laser. Yeah. And we know from the past, you know, that if you do it manually,
even in terms of stability,
then it's
I guess.
worse.
And the reason we did less, that we use more the toric version even in the lower parts, and then only if we couldn't use this lens or it's not available in this, or we just add a little bit of astigmatic component, you know, to titrate the surgery. But I agree with Rudy. We go for toric.
You just bring another, you know, another factor into the equation if you do it in comparison to toric IOL.